So, students, in the cranial nerves, first we have to know a little bit about anatomy of the brain stem. Okay, anatomy of the brain stem, the brain stem nuclei, rule of 4, which I discussed in the theory part. 4 nuclei above the level of pons, 4 nuclei in the pons, 4 nuclei below the pons, and 4 tracts are medial, 4 tracts are lateral, and crossed cruciate hemiparesis, which I discussed, okay, in the brain stem, and some of the ascending and descending tracts, which I discussed in the theory part. So, this is about the brainstem anatomy before discussing the olfactory nerve and optic nerve. Now, first let us discuss the examination of the olfactory nerve. Olfactory nerve epithelium is there situated in the cribriform plate, then olfactory bulb, olfactory tract. From there is connection to the temporal lobe. It be a same like a 8th nerve. You can have a conduction problem or sensory neural problem. Conduction problem anywhere in the nasal epithelium, nasal pathway. Sensory problem in the optic bulb tract, from there to the temporal lobe connection. How to examine the olfactory pathway? Each nostril should be examined separately. The patient should close the eyes. Irritating substance like ammonia should not be used. Common soap, coffee powder, camphor, alcohol, mouthwash can be used. The perception of the odor is important rather than recognition. The perception of the odor is if there is any problem with the olfactory pathway. If there is a recognition, then the problem is in the cortex. Because there is a bilateral representation from the optic bulb and tract, unilateral cortex region won't produce anosmia. What are the different terminologies used in this anosmia? Anosmia is total loss of smell. Hyposmia is a reduced loss of smell. Hyperosmia is increased sensation of the smell. Cacosmia is perceiving as a bad smell. Caprosmia is smelling like a fecal smell. Presbyosmia is old age, where there is a loss of smell. Then what are the cause of anosmias? Commonest cause is rhinitis, the common cold. Then trauma, meningitis, old age, Alzheimer's disease, Parkinson's disease, zinc and copper deficiencies, drugs. Then Foster-Kennedy syndrome, Kalman syndrome. What is Foster-Kennedy syndrome? If there is an orbital lobe meningioma, there will be ipsilateral optic atrophy and contralateral papilledema. Why only one side papilledema? Because wherever there is optic atrophy in one eye, that eye cannot develop papilledema. That is why ipsilateral optic atrophy, contralateral papilledema will be there. There is one more entity known as anterior ischemic neuropathy, where it is also known as pseudo Foster-Kennedy syndrome, where there won't be any anosmia, but ipsilateral optic atrophy and contralateral papilledema. Okay. So, anterior ischemic optic neuropathy, where there is ipsilateral optic atrophy, contralateral papilledema, but without anosmia. That is pseudo Foster-Kennedy syndrome. That is Kalman syndrome. Kalman syndrome is hypogonadotropic hypogonadism with anosmia. Why you get like that? Because during development in the embryology, from the olfactory bulb, the neurons will migrate to the pituitary, the gonadotropic releasing hormones neurons. So, whenever there is a optic bulb mole development, even that gonadotropic releasing hormone also will undergo mole development, and they will have hypogonadotropic hypogonadism with anosmia. Now, let us go how to examine the smell test in him. Smell करो, क्या है?
पूजा करने वाला कपूर.
वेरी गुड. इस साइड बंद करो. ये क्या है?
वो ये कपूर.
ओके, ठीक है. ये क्या है?
कॉफी पाउडर.
ओके. ये क्या है?
कॉफी पाउडर.
ओके. So this is how you examine the olfactory nerve, and you should know the different terminologies: hyposmia, hyperosmia, cacosmia, caprosmia, and conditions which can produce anosmia, Foster-Kennedy syndrome, and Kalman syndrome. Okay, right. So next is examination of the second cranial nerve. Examination of the second cranial nerve is done under visual acuity, field of vision, and pupillary reflex. Pupillary reflex we will discuss under the examination of the third cranial nerve. The other two, visual acuity and field of vision, we'll discuss today. Before examining the visual acuity and field of vision, we should know the anatomy of the optic nerve. Okay, students, we have discussed about the olfactory nerve examination. Okay, now we'll discuss about the optic nerve. Okay, so you know how to examine the optic nerve. Before examining the optic nerve examination, you should know a little bit about the anatomy of the optic nerve pathway. Okay, right, students, this is optic nerve pathway. See here, this is the nasal field and this is the temporal field. This is the nasal field, this is the temporal field. The nasal field will go and will be carried by the temporal fibers. The temporal field will be carried by the nasal fibers. Similarly here, the nasal field will be carried by the temporal retina and the temporal field will be carried by the nasal retina, nasal fibers. So here, this is the optic nerve, okay, and then this is the optic chiasma. A is the optic nerve, B is the optic chiasma. See, in the optic chiasma, students, the nasal fibers are crossing to the opposite side. See here, it is crossing to the opposite side. The nasal fibers are crossing to the opposite side in the optic chiasma. So that's why if there is any optic chiasmal lesion, you get a bitemporal hemianopia, because both the nasal fibers which are crossed will get damaged. These nasal fibers will correspond to the temporal field, so you get bitemporal hemianopia, also known as heteronymous hemianopia. Why it is called heteronymous hemianopia? Because the right eye right side, left eye left side. So different side of the eyes will be affected. That is why it is called as heteronymous hemianopia, though it is a bitemporal hemianopia. That is the reason why it is called heteronymous. Okay, so optic chiasmal lesions will produce bitemporal hemianopia, also known as heteronymous hemianopia. So these are the optic tracts, students, optic tracts. If there is a optic tract lesion, if there is a left side, this is a left side optic tract lesion, patients will have right-sided homonymous hemianopia. That means right side of the right eye, right side of the left eye will be a problem. Right-sided homonymous hemianopia. This and this will be a problem. This is in the optic tract. Then you have a lateral geniculate body. From the lateral geniculate body, you have optic radiation, and then it go to the occipital lobe. Okay, optic nerve, chiasma, tract. D is the tract, C is the B is the chiasma, E is the radiation, and then it goes to the occipital pole. Okay, right. This is the pathway of the optic nerve. So then you should know about pupillary reflex pathway. I discussed how to do the pupillary reflex. Okay, before doing the pupillary reflex, you should know what is the pathway of pupillary reflex. Students, light reflex pathway now I am going to explain you. See here, optic nerve. Okay, it starts if the light falls on the eyeball, optic nerve will carry the impulse. This is the optic chiasma. Then it goes in the optic tract, the light reflex pathway. This is the lateral geniculate body, and before the lateral geniculate body, the nerve will give impulse to edinogenospal nucleus of same side as well as the contralateral side. It has a bilateral connection. That is why it is a consensual reflex. So if you throw light on one eye, there will be a response in both the eyes. So you give connection to the edinogenospal nucleus, and then from edinogenospal nucleus, the fiber will come through the oculomotor nerve, then synapse in the ciliary ganglia, and then it supplies through the short ciliary nerves to the sphincter pupillae, constriction of the pupil. So light reflex pathway is optic nerve, chiasma, optic tract. The pre-geniculate fibers, without going to lateral geniculate body, the fibers will synapse in the edinogenospal nucleus of same side as well as the contralateral side, and then it comes to the oculomotor nerve, synapse in the ciliary ganglia, and then through the short ciliary nerve, it supplies the pupil, sphincter pupil. Okay, students. Right. Now next one is Mayer's loop, just for an interesting purpose. So here are the optic chiasma, and this is optic tract and lateral geniculate body. Okay, so here the fibers which are laterally situated in the lateral geniculate body. Okay, So they take a bend, that is a Mayer loop, and then they synapse most anteriorly in the cortex. Okay, the most anteriorly in the cortex. The lateralmost fibers, which correspond to the nasal field of vision, take a bend and synapse in the anterior part of the cortex. This is called the Mayer's loop. Okay, students. So here the visual acuity will be assessed by Snellen's chart. So the Snellen's chart looks like this. Okay. The visual acuity for vision is assessed by Snellen charts. This is a Snellen's chart. The near vision is assessed by Jagged's chart and color vision by Ishihara chart. So for vision, if the vision is say by 6 by 60, that means a normal person who can see the letter by 60 meters, the patient can see only from 6 meters, that is 6 by 60. Here in this Snellen's chart, it is given in the feet. This is the American system, it is written in the feet. But in Indian system, where there is a metric system is used, it will be in the meters. Okay, I will discuss the acuity again while examining the patient. So students, now you know the optic nerve pathway, the light reflex pathway. Now let us see, and also Snellen's chart, which is used for the optic visual acuity detection. Visual acuity is far-off vision is tested by using Snellen's chart. The patient will be made to sit at 6 meters and will be able to read or not, you will assess it. Suppose if the visual acuity is 6 by 60, that means a normal person who can read at 60 meters, the patient can read only from 6 meters. If the vision is 6 by 60, it is known as a legal blindness. If the vision is very less, then you can use by perception of light and projection of light and finger counting. The near field is of vision, the near acuity of the vision is examined by Jagged's chart, which is kept at a distance of 1 feet. Then Ishihara chart for the color vision. The color vision is red-green usually, it is X-linked recessive inheritance. Now let us go to the examination of the visual field defects. Dear students, this is the examination of field of defects by confrontation methods. Both should be say, eye should be at the same level, the distance should be at 1 meter. Then in all the fields, lateral, medial, superior and inferior, you have to bring your finger. Okay. Gopal, अभी मेरा उंगली दिख रहा है? नहीं दिख रहा है. अभी? अभी? Yeah, so he is able to see now. Temporally, the field of vision is around 100 to 110 degree. Gopal, उंगली दिख रहा है? नहीं दिख रहा है. अभी? नहीं. अभी? So inferiorly, it is around 70 to 80. अभी उंगली दिख रहा है? अभी above is around 60 degree. अभी उंगली दिख रहा है? मेरा साइड देखना गोपाल, उंगली दिख रहा है? अभी देख रहा है. It is also around 60 degree the medially also. So with both eyes you have to do like this. This is a confrontation method. So dear students, you know how to examine the field of defect by confrontation method. It is maximum temporally around 110 degree, inferiorly 75, medially and superiorly around 60 degrees. Okay, now students, here I have told you how to examine the field defects. So these are different types of field defects. Now I want to explain the different types of field defects. See students, here this is a normal physiological blind spot. What you see here, this dark lateral part of the eyes, na? This is a normal physiological blind spot, and here you can see a scotoma, central scotoma. A scotoma is loss of visual field in one area surrounded by normal vision surrounding area. See here you can make out this is abnormal here centrally, but surrounding area there is a normal vision. This is a scotoma. Central scotoma is a feature of macular diseases, central scotoma. Here you can see students in the next B diagram, there is a centrocecal scotoma extending till the temporal crescent. Centrocecal scotoma is a feature of papillopathy. This is a physiological blind spot, what you see laterally. So this is a diagram B. Next, the third interesting is a junctional scotoma. See, junctional scotoma here, see, one eye there is a central scotoma, in the other eye there is a superior quadrantanopia. Here there is a central scotoma and quadrantanopia in the left eye. When this happens, I will show the diagram of the central scotoma. Yeah, here, junctional scotoma. Junctional scotoma. See here, what happens in junctional scotoma is, for example, if there is a tumor here below the optic nerve, this side, the right eye optic nerve papillopathy will occur, so there will be a central scotoma. And because it is pressing the nasal fibers of the opposite optic nerve, which corresponds to the temporal field, and because it is pressing from below upwards, the upper part will be affected of the temporal part. So that is why left eye upper part, temporal part, because the nasal fibers which are crossed will be damaged by this tumor which is pressing here. So the left eye there will be a temporal part, superior quadrantanopia, and ipsilateral central scotoma. This is a junctional scotoma. Okay, students, that is the interesting, the third diagram. See, coming to the D, here see what happens. There is a homonymous scotoma, right side homonymous scotoma. Here also right side, left eye also right side. This is a homonymous scotoma. This is a bitemporal or heteronymous scotoma. See here, right eye of the right eye, right side of the right eye, left side of the left eye. Heteronymous scotoma. And see this F, the diagram F. Diagram F is right-sided homonymous hemianopia. Why right-sided homonymous hemianopia? Because right side of the right eye, right side of the left eye. That is same side of the both eyes. Right side of the right eye, left side of the right side of the right eye, right side of the left eye. Right side homonymous hemianopia you get if there is a left optic tract is damaged. Homonymous hemianopia is a feature of optic tract problem, optic tract nerve problem. And see here, bitemporal hemianopia, right side, also known as heteronymous, because right eye right side, left eye left side. Bitemporal, also known as heteronymous, you get in optic chiasmal lesions, like a pupillary adenoma. So this diagram H is congruous homonymous hemianopia. See, it's equal in both the eyes, the field defects, equal, congruous. You get this in a occipital lobe optic radiation problems. The more nearer to the optic nerve, you get congruous like this. This is incongruous, you see in the eye, diagram eye. One eye there is a homonymous hemianopia which is unequal compared to the left eye. Right eye vision is little different compared to the left eye field defect. Incongruous, you get little away from the occipital cortex when problem occurs in the radiation, which is little proximal. This is a right superior quadrantanopia. This is right inferior quadrantanopia. Okay. And this is a macular sparing. You can see macular sparing in L. Diagram L, there is a macula is spared. This you get whenever occipital lobe is damaged, because it has a dual rich blood supply macula both from middle cerebral artery and posterior cerebral artery. Okay. So these are different field defects: central scotoma, centrocecal scotoma, junctional scotoma, homonymous scotoma, heteronymous scotoma, homonymous hemianopia, bitemporal hemianopia, also known as heteronymous hemianopia, congruous hemianopia, incongruous hemianopia, superior quadrantanopia, inferior quadrantanopia, macular sparing. Okay, student, this is about the field defects and junctional scotoma. So what are the diagrams I have taken? I acknowledge De Jong's Neurological Edition, 7th edition. Okay. So students, you came to know what are the different types of field defects you get. Okay. So after examining the field of defects, okay, next the second nerve examination is not complete without the examination of fundus. In the fundus, the three things which you will see is papilledema, optic neuritis, and optic atrophy. In papilledema, there will be a disc edema. There are some conditions which produces papilledema: rise intracranial tension. Rise intracranial tension may be due to a tumor, abscess, or a stroke, or a meningitis. Central retinal vein occlusion. Then Foster Kennedy syndrome, which I discussed, orbital frontal lobe meningioma with ipsilateral optic atrophy, contralateral papilledema. Then any intracranial tumor will produce papilledema. Pseudotumor cerebri. There are some drugs which produce pseudotumor cerebri like nalidixic acid, tetracycline, oral contraceptive pills, steroids, hypervitaminosis A. Pseudotumor cerebri will produce papilledema. There is some entity known as pseudopapilledema due to myelinated fibers in the optic nerve and also drusen, optic nerve drusen. That is pseudopapilledema. In a papilledema, the patient's peripheral field will be considered, but he can see. Even a doctor can see with a fundoscope the papilledema. So, in a papilledema, a patient can see, a doctor can see. Next is optic neuritis. In optic neuritis, there will be hyperemia of the optic nerve head. The conditions are infective, the viral infections like measles, mumps, multiple sclerosis, B12 deficiencies, toxins like methyl alcohol, this can produce optic neuritis. So, in optic neuritis, a doctor can see the abnormality in the optic nerve and patient cannot see. Whereas, in a retrobulbar neuritis, even doctor cannot see anything, patient also cannot see anything. Retrobulbar neuritis and optic neuritis can also be produced by drugs like INH, streptomycin, ethambutol. Next is optic atrophy. In optic atrophy, the funda will appear like a chalky white. The etiologies are glaucoma, long-standing papilledema, optic nerve glioma, the tumors, hereditary optic atrophy like Leber's optic atrophy, hereditary ataxias, then Foster Kennedy syndrome, which I told, ipsilateral optic atrophy, contralateral papilledema. Another cause of papilledema is grade 4 hypertensive retinopathy, which I didn't tell. Hypertensive grade 4 retinopathy, they have papilledema. So, in a fundus, you will examine papilledema, optic atrophy, optic neuritis. So, this is the examination of second cranial nerves. Thank you.